topic of this talk is the impact of changes in healthcare on minority communities. And this is something that's not only very near and dear to my dad, but also is very near and dear to me, and something that's very important. And hopefully give you some food for thought today and some way of looking at things a little differently about how managed healthcare has worked and has not worked for minority people of color communities and for those of us who service them. I find that a little outline always helps know where you're going. So we're going to start with the background, and then we're going to talk about the times. And I'm sort of enjoyed that. I mean, my dad, he had times. I mean, even changed this to the times they are changing more rapidly than we would like them to change in some cases. The impact on minority communities and providers, where I'm going to spend most of my time, and policy and initiatives, and some of the things we're doing in California that are a little different. Californians are sort of thought about as being different, so I guess I'm going to confirm that today when I talk about some of the initiatives that we develop. But use this as sort of food for thought about some of the things you're doing and may be doing to deal with the different changes in healthcare. This slide is sort of a history. Is that focus for people in the back? Oh, let's play with focus. No? Yes? Better? Worse? Better? Yes? Better? You guys can read now? All right. This is a very detailed outline, but you are going to get it. It is going to be in the book. We did finish the white paper, which my dad will be faxing, so you don't have to fast and furiously take notes. This will all be available to you, so you can enjoy, sit back, relax, and enjoy yourself, which is what my United pilot was saying this morning. As I was on the plane. There have been 4 major reports done on the disparity in health care and how minority communities suffer excess deaths, and these are the 4 important ones. What I just want to say about them, the first report came out in 1968, which was the Kerner Commission report, which was after the assassination of Martin Luther King, and looked at the race riots and what was causes of the race riots following his death. And healthcare disparity was one of them in terms of outcomes, in terms of illnesses. That was looked at as a possible causative factor in those riots. And then the last one, done in 1995, was done by the AMA, which basically documented that all the things they'd seen in 1968 as disparities still existed, and in fact the gap had grown. So this slide is just to serve as a reminder that the healthcare disparities that exist in terms of types of illnesses, in terms of health outcomes, in terms of life expectancy, are very different for people of color in the United States. And that hasn't changed and isn't changing. So that's what this slide is for. And I just unfocused it for you guys. You guys are going to all be cross-eyed at the end of this presentation. If we look at the times and what the biggest changes are and what's happened with the changes, there are a couple that are important. One is the managed care. We moved from fee-for-service and sort of fee-for health care plans that we're familiar with to managed care. And that has greatly impacted minority communities because a disproportionate number of them are going into managed care plan. When we talk about California, you'll see why. There also is this merger mania where we see all these HMOs and different managed care plans all across the country joining, shifting the way they do things, shifting the way they look, shifting their clientele. So there's that piece that's also important. We also are seeing capitation, and capitation is very important when we're talking about minority communities and those of us who provide services to minority communities, because they tend to be sicker, they have more comorbidities. If we look at the illness pattern and the outcomes and just the health education these communities have, they're at higher risk. And if you're on a capitated system and it does not make allowances for the type of patient you're seeing and the increased acuity and higher risk patient that you're seeing, your service is, in a sense, you feel that your service is being devalued. So the way you do service delivery changes because of that. So capitation has not been necessarily friendly for minority communities for that reason. Medicare managed care, my colleagues earlier today, and it sounds like in your groups you've been talking about that a lot, so I'm not going to go through that, because what I want to spend time with is talking about Medicaid managed care in California, otherwise known as Medi-Cal. And I'm going to go through that story with you, the history of Medi-Cal and managed care in California. Well, California has approximately 3.4 million people that can go into a managed care plan, and the state decided that because of a whole variety of things, federal waivers and all that sort of stuff, they needed to move that population into managed care. Now apparently approximately 1.9 million people have entered some form of managed care plan in California. The goal is to move them all within the next year. So we basically went from fee-for-service for these clients into managed care in 2 years or less for 3.2 million people, okay? What the California Department of Health Services did was they did a pilot, which we all know is very smart, to look at how effective a managed care plan could be. Now, what's very important about this pilot, they did it in 4 counties all across the state. They involved all the major stakeholders, so patients, providers, healthcare plan, insurance, private and county and state, all sat at the table, and it was a local table they sat at, and they designed the plans. The pilots are very successful for that reason. They had all the stakeholders involved. They looked at all the issues from a variety of different perspectives, and they had very solid governing boards and people who knew what to do fiscally, very tight fiscal management. So the pilots are very successful. California said, aha, this is a good thing. It will work based on these pilots. Well, what they did after that was they moved to the rest of the state, and they went from the pilots to what they call a 2-plan model. They threw out the pilots and didn't use any information from them. Now, we can all imagine what's wrong with this picture. And sort of, why do the pilot if you're going to chunk it all and get rid of it? So they did this untried, untested 2-plan model, which basically is a state-county model with a capitated managed care plan run by the local county versus a private market plan run by Blue Cross Blue Shield. Blue Cross got the contract, and they opened it up for bidding in California. So we went from this pilot to this 2-plan model, which had some inherent problems, one of which I just talked about. The second thing when they designed this 2-plan model is they didn't involve any stakeholder. It was purely an administrative decision. So in other words, the County Board of Supervisors got together and said, this is what the plan's going to look like. No patients, no providers, just the County Board of Supervisors and the County Health Department. And with the Blue Shield, it was them that got together, made the decision, no patients, no providers. So we had this dual system again that existed. People were going, California, I thought you were smart. Now I'm wondering. The other thing that happened in this 2-plan model that they set up was that welfare reform got passed at about the same time they set this up. So now they have this federal mandate to move these patients faster than they had initially tried to move these patients. So we have something that's untried and untrue, something that hasn't involved any of the major stakeholders in terms of patients, clients, providers, and we have something now that has to move according to federal mandate. So we set ourselves up for problems in California. Patients now had to meet the federal requirements and meet the state requirements. Do any of you practice in California besides me? The provider enrollment packet that went out to clients was thicker, was about 4 of your syllabuses here. By the time you added welfare reform on top of the whether it was Blue Cross or the state, that's what was mailed out to the populations that had previously been fee-for-service Medi-Cal, who have problems with literacy and a whole lot of other things that I'll go through. Needless to say, they had this thing called default, which means that if you do not sign up for a plan, you get assigned. In Alameda County, where I work, 85% of patients were assigned by default, not by choice, which meant literally you would show up, like in my office at Children's, to be seen. You've been a patient there for 6 years, and we could not see you because you now had a doctor who you had never seen, who might be 20 miles away, who by default became your provider. Had a lot of hysterical patients. I still have very hysterical patients and parents. And when I called to see, the question asked was, have they ever seen this person? No, they've never seen this person. They've been here the last 6 years. And then the question was, the next thing was, well, we can't change them over to the 1st. So if you're like on the 2nd of the month, you can't be changed to the 1st of the next month. So we were seeing all these problems with this default plan. What was very fortunate for us at Alameda County was the local county medical society got involved and said this is not working, and now we have provider enrollment. So you as a provider can have forms in your office that actually disenroll and enroll your patients when they come in the door. So the defaulting has moved from 85% to 10%. But that was because we have very active, very involved local medical society that stood up and screamed. It was disastrous when it first happened. I won't go through the state contractors' problems. Suffice to say, if you put a bureaucracy on top of a bureaucracy, it doesn't work real well. physician problems who've come through the LA experience. How many of you didn't hear about what happened in Los Angeles where President Clinton basically had to bail them out when they went to managed care? They lost billions of dollars, went into bankruptcy. Actually, we're talking about closing all their hospitals, all their clinics, all their minority health service providers were like no longer going to be in existence, and the president bailed them out with a waiver. How many of you saw that in the local newspaper? That's real. It was very scary. My stepmother is a senator from Los Angeles. Suffice it to say, her blood pressure probably was 200 over 120 the entire time that was happening. Because the community, basically, in some communities, especially minority communities of colors, all the health service providers, their offices, the clinics, the hospitals were closed. So, what did we learn in California? What the impact, the real impact on managed care was on minority communities was this: disaster and chaos. Everybody was scrambling, nobody knew what was happening, and we had a lot of patients who fell out of the safety net, ended up on the streets, weren't seen by anybody, came back higher acuity, stayed longer, cost more. How many of you are familiar with that cycle? But there are specific issues that have to do with patients that are minority patients and that are important for you to think about and for me to go over. One of them is, when we talk about minority communities and communities of colors, those are people who are more likely to be uninsured or underinsured than the general health population. So that already puts them at risk. We've already talked about the fact that in terms of disparity of health care, the outcomes, the type of illnesses, the timing of the illness puts them at risk. It is very different from the general population. So they're already at risk for that reason. The literature has been very extensive in terms of identifying specific illnesses. Cardiovascular disease is one, HIV is another. We can go through them, and most of you are familiar with them. They also have a higher incidence of comorbidities with illnesses and a higher incidence of chronic illnesses, which also puts them at risk if we look at this patient population. Not to mention, on top of that, we have cultural and linguistic differences. A lot of communities in California, that's the sort of nice thing about practicing in the Bay Area. I have curanderos, I have shamans, I've got Native American healers, you name it, it comes through the door at Children's Hospital, Regional Medical Center. We have huge Southeast Asian, Latino, Mexican, African American population. We see a little bit of everything. But when you talk about implementing managed care in that sort of arena, you're going to have cultural and linguistic problems that are going to complicate anything you try to do, even if it is fee-for-service, but especially if you're dealing with managed care. And when we talk about minority communities, the other thing that puts them at risk and makes them different from the general population is they often have very limited or very poor experience in negotiating the healthcare system that we're so familiar and comfortable with. So if you add on top of that, now I've got to fill out a form that's 4 syllabuses big, and I've got to be able to read English and write in English to do it. That's an additional barrier that we've added. So what we saw in terms of the impact of managed care on these communities I just talked about is that there was increased complexity. We can imagine what happened because of that, and I'll come back to that in a second. There was default that was occurring, irregardless of whether they negotiated their way through those 4 syllabuses and signed on a provider. If it wasn't done in the right amount of time, they were defaulted to this provider who they may or may not have known, they may never have seen. What they thought, by setting up this 2-plan system and having Blue Cross, private provider, and the state, would ultimately end up in increased freedom of choice and give the patient some choice, actually increased freedom of choice, actually ended up in decreased freedom of choice because patients were defaulted to one or the other system. They didn't know how to exercise freedom of choice, so it really didn't exist. There was a huge disruption in provider-patient relationships because of the fact that somebody you'd seen for 10 or 12 years may or may not be assigned to you, the way the plans were implemented in California, which interfered with continuity of care. And it's very interesting, being in adolescent medicine, you know how teens are, they come tell you what you do real good and real bad, whether you want to hear it or not. Most of my teens had a running commentary about this while this was happening. And my conversation with them, when I would go out to talk to them, was, how can you tell me you're interested in my health if all you're talking about is, I don't have my health care card, or you're not my provider, I'm now going to be turned away, and you say you're interested in my health, what I think you're interested in is whether I can pay or not in the dollars. That's a real interesting conversation I have with the teen. And then the other thing was, you expect me to know how to negotiate the system, and you expect my parents to know how to negotiate the system, and they can't. So what does that mean? I stay out, I'm not going to come in, and I'm going to tell them not to come in because this is not user-friendly for us. It doesn't work for us. These were like 12, 13, 14-year-old teens. So, in between all their other high-risk activities, felt it was necessary to give me a commentary about how managed care was impacting their lives. If we look at specific results, the things that are important is that we can't expect minority communities to act as educated, informed health consumers, because often they have different healthcare systems than our traditional healthcare system, which they are just as reliant upon, and the traditional healthcare system as designed has not worked for them, and they're not familiar with it, so they don't use it. And now we've added an additional barrier. There's decreased prevention, a different focus in terms of intervention for these communities. There is increased emergency room utilization. If you look at the most recent statistics for minority communities, the emergency room utilization has actually gone up and not down. If you don't know what to do, when all else fails, you show up in the emergency room for care. You stop using your primary care provider. You stop using the person you see, because that provider is no longer in the loop. So continuity of care falls off, provider-patient relationships get put at risk, and we have added cultural and linguistic barriers. This whole concept of cultural competency, how many of you are familiar with that? We have this huge thing in California where we're trying to look at making healthcare providers culturally competent. And in some of our more sophisticated managed care plans, there's a book about what you should be able to do as a healthcare provider to work with people from different ethnicities and different cultures to make yourself culturally competent. And some of the people just laugh at that and say, if we were to put an Italian or a French or German cultural competency, if we were to do the same thing with some of the more mainstream European countries, you guys would be real offended and real ticked off. But you think it's okay to do it with us. So the whole issue of cultural linguistic barriers is a big one, and one that we haven't figured out in California how to hurdle. But it's very important. It's an additional obstacle of managed care. There are some specific provider issues. In general, physicians who do work with minority and ethnic communities tend to have an increased share of patients who fall into managed care plans, especially Medi-Cal patients in California. So that's very important. So the patients tend to be sicker, they tend to have less information, they tend to be less educated, they tend to have higher acuities, and these providers have served as safety net providers in the past, and now they weren't even asked at the table. If we look at the private insurer Blue Cross, Blue Shield, the providers were not even asked how the plan should be set up. So they're already starting at a deficit. And traditionally, the providers did not have relationships with these private plans. They served as safety nets in different community settings. They have never developed relationships, and they just get literally cut out of the equation. They're not even considered when they're putting together rosters of who should be enrolled as a provider, and that's a problem. If we look at the impact of managed cares on these providers, we've already talked about capitation and how that has impacted them. There are major decision-making shifts that have occurred for a variety of reasons, where the provider feels, for whatever reason, be it legitimate or not, that because of gag rules, because of enrollment procedure, because of incentives, because of disincentives, because of being put out of the plan or not even invited to the plan, they are not making the decisions for their patients, and so they abdicate responsibility at some level. And that's dangerous when you're talking about somebody who's sicker, not as healthy, and you're talking about having to do a tertiary measure versus a primary measure. And the whole issue of provider eligibility, provider referral networks have been disrupted, and patient-provider relationships that have been traditional, long-standing, 20, 30 years we've seen been disrupted. I mean, I've only been at Children's 12, and I know that for 30% of my patients, they all of a sudden were bounced out of the system by default. Now, we've been able to recoup them, but during that 6 or 7 or 8 months where they're running around without a medical home, where I was no longer the primary care provider, and whoever I was trying to call to get to see them refused to see them, or for whatever reason they weren't being seen, I now have to catch up and make up that ground work. So that's an example of how it is not necessarily impacted positively. So what do we do? Can we have the lights up for a second? Do we just sort of wash our hands? Lights, lights. Guys got to be awake. That's why I'm cutting the lights on. Yeah, I can't go to sleep, and I'm at California time. What makes you guys think you can go to sleep? I don't think so. I don't think so. That's bad, isn't it? You can tell I'm used to doing this, making sure you guys stay awake. What do? You throw up your hands and say, oh, can't deal with the managed care environment. Oh, I'm a provider, and you have to keep reminding, I'm in a teaching hospital, but MD behind MD does not stand for medical deity. I have residents who are very confused about that, They come in from UCSF, some other places, but I have this MD behind my name, and doesn't that mean medical deity, and I shouldn't have to listen to? No, no, no. There's a very different arena, and there's no question that we have to learn, we have to become comfortable with managed care. And I liked one of the speakers earlier today because he was talking about a new way of looking at things. I don't think the two are mutually exclusive. I don't think medicine can be a business or should be a business, and I don't think that we're all as altruistic as physicians as we necessarily put out to be. But there is a meeting. It's not either or. There is a meeting that has to happen, and it has to happen quickly for minority communities, because while it's not happening at this point in time, what's happening is people are dying. Those of us who work in minority communities are literally have increased the body count for a variety of reasons, which I've talked about. So you can do a couple of things. One, you can go to organized medicine, or you can design and implement strategies for working within these communities under this current climate that work for you. And one of the brainstorms that we are now dealing with is called the Ethnic Health Institute, which is a partnership with Summit Hospital, Children's Hospital in Oakland, where I work, my dad's at Summit, and Kaiser Hospital, where they've come together and they developed a paradigm. And I have to say this is my dad's paradigm, so I'm being Frankie Staggers Sr. for a minute, shift hats. It is this paradigm and his way of looking at and solving the problem. Managed care, Medi-Cal is my dad's thing. And what he's done is basically moved from a scientific, traditional way, a more static model looking at medicine, to an open sort of the art of medicine. Instead of the business of medicine, we're now trying to go back to the art of medicine for minority communities. And it's very comfortable for the communities they're working with in the Ethnic Health Institute, because it fits in with the paradigm and the shift and the belief that these communities have. So we're talking about going from walls to no walls. So what do I mean when I say no walls? What happens in the Ethnic Health Institute? They have health ministries. One of the big partnerships in the Ethnic Health Institute is something called St. Luke's Society. When you guys who are smart can figure out St. Luke with both a physician and a pastor. This is an alliance with all the physicians in the area and all the Baptist ministers in the area, where they sit down and talk about how they have things in common. And because of this alliance, people actually go into parishes and do blood pressure screening, prostate cancer screening, breast cancer screening, for my population, pregnancy testing and abstinence counseling. A variety of things where because of the parishes, for the pastors, there's a direct involvement between the health service provider and that pastor or that parish. So there's a ministry of health that is developed with the Ethnic Health Institute, which really is in the community and doesn't have walls. It's not practiced traditionally. The nurse, the physician, the healthcare team go out to the church and deliver healthcare services there. And conversely, the pastor may refer to their own church for healthcare services and delivery to be done. So it's a different sort of model. That's one of the things the Ethnic Health Institute does. The other thing the Ethnic Health Institute is looking at, and in my introduction you heard that we have this nonprofit called Tiger Medics, is looking at relationships and liaisons with things that we traditionally did not look at, having liaisons with schools, juvenile court systems, parks and recreation. Those are good places. I mean, even be in the malls. You guys may come visit me in California and I'll be at the malls at the nail shop, because that's where my teens are. You know, they can't eat breakfast, but they can get those $50 nails put on with the, diamond in them. So maybe I need to be at the nail shop, because if I wait for them to come to me at Children's Hospital, they're not going to ever see me. But if I go to the nail shop where they're getting their nails done, I can have a very interesting conversation with them. So what the Ethnic Health Institute is looking at is where in the community you can provide services for certain populations that are at risk because of their behaviors. Going to them, not waiting for them to come to you. So that's one of the brainstorms. What my dad made me promise I would do is leave you with something that happened in our parish recently with a young lady who was an honor student at UC Berkeley, was coming home from taking a qualifying exam, was getting ready to do a master's program, and was broadsided by a car. And hit the retaining wall, which is always interesting to me because that's supposed to save you, right? Well, the retaining wall she bounced off of and was hit on the driver's side by a truck, and was in the hospital with like 10 major things: lacerated liver, spleen, 9 rib fracture, pelvic bone broken in 2 places, major brain injuries and everything else. And what I remember when this young lady's name was Kyra, when this happened to Kyra, was that a call went out to the church members to pray. And to the physicians in particular, not just to pray, but to, when they were in making their rounds and they were taking care of Kyra, to pray as well. And that was not totally alien or was not unfamiliar. I'm real clear as a provider that there's some things I have control over and some things I don't have control over. And they're in hands greater than mine. And it went from them saying Kyra's not going to live to Kyra's going to die for sure to, oh, Kyra got better. to Kyra passed her GRE, to now Kyra's in the master's program at Berkeley. And what's probably most telling about the experience of Kyra, and I think why my dad wanted to talk about this, was it required us as physicians to be very non-traditional. And Kyra was a managed care HMO patient, which will go nameless, but you can guess which is the biggest HMO in California. I have to say that. The experience, and the parents did a lot of things that were not in the healthcare plan that they said too bad, and the physicians who were on the inside and outside were supportive of that, and the system worked for them, is that when Kyra was able to talk about what had happened, she recalled being in a long line of people going up a slope, and she was pulled out by two individuals who she says she knows were angels, and not what they were like, angels like we think with little wings and a little halo, no. But she says she knows they were angels, and what they said to her was, it's not your time, you have to go back because people are praying for you. And that was real telling. My dad said it sort of reaffirmed for him that the mission of community service and liaisons between ministries and physicians and looking at issues like managed care from more a non-traditional, a way of looking at medicine, and look at medicine as being healing, look at medicine as being an art form and not a business. That's particularly important for communities of colors and for minority communities, but also is extremely important for those of us who service those communities. And we have to be clear about that, and that's not something we can or should negotiate, or something we should compromise on. And often in the managed care market, I know I get called upon as a division chief in a major pediatric regional center to change the way I do things because of changing economic barriers, because of a whole host of things. I now have 20 managed care provider plans that I have to belong to service kids in my clinic, and that includes the state two-plan system. And it could drive me real crazy. The one thing that I have to be consistent and clear about is that the way I practice medicine, I believe in, and that it's more than a business for me, because I don't think you can put a price on a human life, and I refuse to be in any system that does that. So managed care may be able to work for us, and it may be better for fee-for-service, and hopefully what I've done in this talk is giving you some problems that exist in the way we did managed care in California for communities of colors and ethnic minority communities. But more importantly, what I hope I've done for you is make you think about the way you practice medicine and to ask yourself the question, do you practice the art of medicine, or do we want to be about the business of medicine? Teens are real clear. I can't be about the business of medicine in my clinic. It doesn't work because for them, they've gotten the idea, be it right or wrong, that they are less important than money is, because that's what gets marketed to them, is lifestyles, money, material things. And so I got to argue on the other side of things, on humanism and human value and human worth. I can't do that if what they see when they come in my office negates that. So I've got to figure out how to marriage, and I haven't figured it out yet, but we know what we did in California ain't working and isn't working real well for the communities. I'm not sure what the answer is, so I'm not here to give you a cook list or cookbook, because I don't think you can have cookbooks, but we have to think about it, because the reality of the situation, we do have a limited amount of resource. We do have dwindling resources, but does that mean that we X out or forget about communities that are different, that are less healthy, that are sicker? And if we are going to do that, then let's be honest about that and be upfront about that, and not say, no, we care about you too, folks, we just don't know what to do with you. If we're going to X them out, then let's be honest about it. Let's not say one thing and do another. We need to walk what we talk or not talk, and that's the adolescent piece of me talking. Thank you very much.
If there are any questions, we have some moments to engage in a discussion.
Before you ask questions, I should tell you I have a black belt in karate, so it's the wrong question. You may have to call your managed care plan. No, just kidding. No. Good.
I'm just curious with, other things in California where industry, military has left, the new question about the illegal alien, et cetera.
Oh, yes.
Have you seen
209.
other polarizations occur that manifest themselves in healthcare? Presumably there's a dwindling resource, and what has that done between the African American and the white community or whatever?
Yeah, you're talking about Proposition 209, where, I have a 12-year-old home, and he said, what's an alien? We do have illegal, what's an alien, Mom? Because he's thinking about aliens, in the movie. No, son, that's a term that they use. I was trying to describe it to him. Proposition 209, the whole issue of turning in undocumented women, children, men who are not in this country legally is a real problem for healthcare providers and has served to polarize further people who need to be seen and will not come in because they're afraid of that happening. Recently, we just had a stay put on where at the end of this month, actually, we're supposed to be that we could no longer service undocumented women who were pregnant, for example, that we could no longer offer prenatal services, prenatal care, or anything, and they were basically supposed to be shipped back and deported if we found out they were undocumented. There's been a stay put on that, and now the court will hear it before September where some sort of decision will be made about that. But I think that propositions like 209 serve to further alienate certain minority and ethnic populations, and they serve to make it harder as healthcare providers. You know, I'm going to have time to ask, by the time I get my secretary on the phone to argue with the managed care, whoever the healthcare providers, I don't have time to ask, oh, by the way, can I see your green card, can I see your passport? I mean, did you come in? I mean, so sort of at some level, the way some of us practice medicine, we just don't ask, so you don't know. And with teens, it's probably a little different because teens are eligible for services regardless of who can pay, and we make a decision to see it doesn't make me popular in the hospital, which is, you know, looking at every penny that comes in. But I think those are questions we have to ask ourselves. I have to go to sleep at night before I have to deal with balancing the book and making sure the hospital comes out in the black. So that's a long answer to a very difficult question. Yes?
Would you elaborate a little bit more? I think you said that you were involved in absence counseling for the teens.
I was hoping as an adolescent person. Yes, go ahead.
Well, I was wondering if you could elaborate a little further on that. I think those are important policies. Is that something that you're doing privately, or is there state
No, I think
money?
the Ethnic Health Institute supports us in doing that privately. You have to look at, you know, I'm a PD pod first. I'm a pediatrician adolescent specialist, so I tend to approach things developmentally. And the whole issue of abstinence and the academy, I sit on the National Committee of Adolescents for the Academy. I was just here for a meeting. And the whole issue of abstinence and how you support abstinence and be the primary, secondary abstainers, you know, teens who have had sex before and then decide that you can encourage them. What goes into that is very important. We have found abstinence support groups are very helpful, where we have other teens supporting teens around that. So it's not just policy per se, it's it's a way that the community has decided they want to support their teens and be consistent in what they say. We also do reproductive health and other things as well. Yeah.